Our next speaker is a former physics classmate of mine. I'm delighted to introduce Samantha Du Plessis. She's an experienced radiopharmacist who has worked in various sectors, affording her the skills in radiopharmaceutical manufacturing, compounding, and also business development. She's the program manager of NTP with keen interest in targeted therapy. Welcome, Samantha. We're looking forward to your talk.
Thank you very much. Hello, everyone. I really enjoy how these talks follow on top of each other, because I think a lot of what was said in the last two speakers actually kind of fits into what I want to say now. And I want to say I've got good news. I know we do often, at these conferences, look at all the problems and things, and we do offer some solutions. But to me, this is actually a good thing. So the guidelines that I'm going to just present just as an overview kind of force what we need. So I'm going to go through the operational guidelines of the IEA I'll talk to you, and then also the new guidelines, which will then force the situation further to say that, look, we've got many radiopharmacists, we've got qualified ones, we've got ones that can register, but how do we then incorporate them into the system and make it work? So we need to start somewhere. So let's just hope that I can do this. Right, okay. So I'll do an overview of just why I'm doing this. As I said, the guidelines. The value chain plays a very crucial role, and I think this is also to support the industry, not only in South Africa, but also in Africa. I'll explain the guidelines, the operational part, and then also the risks. So the purpose of guidelines in general, and the purpose of why I'm explaining the guidelines, is so that we can ensure safe practices and products. We need to look at the risks of compounding practices. I'll explain compounding as well. And then we also need to define the boundaries and the scope of practice of each of the key role players in these guidelines. And then also to provide advice. It's not just a rule book, they're called guidelines, and they do offer advice as we go along. So the first one is the IEA guideline. It's a very old guideline, it's 2008 already, but it's still very relevant, and it was a very practical guideline. It did provide it actually defined the operational levels in three, operational level 1, 2, and 3, and told you, it actually explains exactly how on each level where you as a hospital radiopharmacy needs to position yourself in terms of staffing, in terms of training, facilities and equipment. Then the next one is our new one, is the one that Marek also spoke about, is the guideline for good medicine compounding practice, the one that's out for comment. This is, I think it's quite a relief to have it. They don't specify radiopharmacy in it yet. The word radiopharmacy is not included. However, compounding in general is included, and I think the intention of this was also to just give some guidance on the requirements that are required, and also gives, I think what makes this one different to the IAA one is it doesn't only include the hospital practice, but also the retail and the commercial parts of it. So it's more focused on pharmacy. They don't speak of radiographers and nuclear technologists and medical physicists in this. So I think this is going to be quite important for us as pharmacists, I suppose. So compounding has been quite a controversial word. A few years ago, we weren't allowed to use the word compounding because it was frowned upon, because it almost seemed like we wanted to shy away from a manufacturing license if you speak about compounding. But these days, compounding is actually acceptable. So compounding it's in the guideline, it's in the Medicines Act, as the preparation, mixing, combining, and packaging and labeling of any medicine by a pharmacist or suitably qualified person, which is then licensed in terms of the Medicine Act. We've got, let's look at this. Okay, so the value chain, and why I just want to stick to this a little bit to say, we've got the R&D, you guys know we've got the nuclear reactors that we've got API manufacturing at NTP as an example, and then final product manufacturing. So this part of the value chain is not described in these guidelines. These fall under your good manufacturing practices. However, they play a key role in how do we move forward and the support that the rest of the value chain will need. So can I go back one? So distributors and radiopharmacies, they then supply the nuclear medicine physicians in hospital settings, whether it be private or state. So you'll see there's like a strange little triangle. So this is because it depends on our product. If you've got the cyclotron product, you obviously go through your reactor part, which is your cyclotron API final product all in one, and you need to supply it directly to the hospital. We can also supply directly to a pharmacy or a distributor, which then supplies to the hospital. So we've got quite a few ways to get it to the doctors, but then each of those has their own regulations as well and licensing requirements, which is important. So let's just look at the operational levels. I said there are 3. On operational level 1, you've got 1A and you've got also 1B. So 1A describes the dispensing of diagnostic unit doses. So this is typically where no compounding is required. You phone the pharmacy, you say you want an MDP delivered for this time, they come and drop it off, the name's on there, everything is ready for the pig just to inject. So when I go through these levels, you must already start thinking, what kind of staff do you think you need? What kind of facilities do you think you need just to perform that specific act? 1B goes over to the more therapeutic things, so it's iodine capsules or your solutions that you would typically get, or even a labeled dose of lutetium PSMA, or something that's already labeled. On operational level 2, it moves to 2A, which is for closed procedures, and I do believe that most of our facilities are actually geared up to 2A, because this was where we started with radiopharmacy, where everyone got a generator, we've got cold kits, and we used to make our own things. Only after that did the private sector really move up to 1A for obviously efficiency reasons, and we don't have enough staff to go and prepare everything. And also cost-wise, it's more cost-effective sometimes for smaller practices to use a pharmacy for single-dose dispensing. So 2B is where we go to the open procedures of white blood cell labeling or platelet labeling. Think again what equipment you would need, what safety net you would need, what kind of people do you need to move to 2B. So operational level 3 is really where us as pharmacists will play a role, but also where your practice, you need to make sure that your practice is geared properly. So 3A is open procedure compounding. So this is where you either have buffers and peptides and you mix and you cook something up, or otherwise do modifications on certain kits, either to extend the shelf life or add chelators. I know there's a few hospitals, or the tertiary hospitals, those that have radiochemists, they normally play in that field. 3B is where I like to play, and that's in the therapy. So this is when we label the therapeutic agents, whether it be lutetium, actinium, terbium. And there's so many more that we're going to introduce later. But this is where, think about 3B and where the pharmacist then will play a role after that. So 3C, and as I said, this is quite an old guideline, but it's important to note with 3C is they speak of the synthesis of PET radiopharmaceuticals. So it's typically like the little company of Mary, where we've got the cyclotron in the hospital. The only thing with that is that doesn't only fall under these operational guidelines. That does fall now, you need a GMP license to be able to operate that. They have, interestingly enough, put the long-lived generators like your gallium generator and your rhenium generator in there. I also believe because it was so old and the type of labeling procedures were so complex. Since 2008, obviously things have improved. We've got nice little units from ITM or from Itemba Labs. And then you've also got cold kits. So having a cold kit with a long-lived generator could actually move it up, back a level, if I can call it that way. So the risk with the long-lived generator is obviously your microbial contaminations and testing and things like that you need to do often. I think most of the previous speakers have spoken about roles and responsibilities, so I'm not going to hammer on that, but I think it's important to note, and these are just 4 key responsibilities or roles of each of these practices. You've got your radiographer, which normally does your capturing of your diagnostic images. They assist with certain nuclear medicine procedures. I think in South Africa they probably do a lot of them. But this was actually the intent of the radiographer initially. Then there's the nuclear technologist or the radiographer that's specialized, where they've then gone additional skills and training to actually administer these radiopharmaceuticals and operate the equipment and interpret images, obviously with the doctor and so forth. Then comes your radiopharmacist, where we are trained to prepare and dispense, do the quality control, look at the regulatory things, look at the proper use of the medicines, and then you've got a radiochemist. So I think the radiopharmacists are quite scarce in South Africa, but a radiochemist, I think, is even more. I think I can count on my one hand the radiochemists that I know in South Africa. So they are then there to design and synthesize these traces, to develop and analyze all the isotopes that we do, but also for research and collaboration. So here's a summary of the requirements, so you don't have to go read the whole guideline. If you can have this, it's a nice, just a summary of it that lists the products that I've gone through now already. But you have to look at the personnel and the facilities. Again, think of your own practice and kind of just pitch yourself where you think your practice is. If it's 1A, it's fine. The personnel that you need is a radiographer or a technologist. The facilities and equipment is quite basic as well, and so also your quality requirements. Let's just look at 2 or level 2. We've got the generators. So technically in the IEA guidelines, you still only need a nuclear technologist. But with the new guidelines coming out for South Africa, so the IEA they don't overrule the local guidelines. It's supposed to just to add value to it and give advice. But the local, the GMCP, that's going to be a tongue tie, the GMCP guidelines will include a radiopharmacist even on that level already, if you look at the word compounding and what is required for compounding. So whether it be a full-time, whether it be part-time, whether it be a pharmacist that's employed to do some of the other stuff that just signs off, those guidelines will detect. The reason you need that is also because of the batch records, the quality control of that level of operation. On 2B, obviously, you've also got the radio labeling of the white blood cells, and there you've got your microbial environment testing that is required. So I think a lot of our practices work on that level, and it's fine. I think our nuclear technologists and radiographers are well trained and skilled, but unfortunately, as soon as the GMCP guidelines are adopted, that won't be enough anymore. We're going to have to look at pharmacists. So hopefully that will then force the Pharmacy Council to look at the specialization again so that we can actually get them employed. Then on level 3, I don't think we should be operating in level 3 if you don't have a radiopharmacist and a radiochemist at least available. As again, it doesn't have to be permanent. It can be on locum basis. It can be part-time basis. But if you look at the equipment and the QA and the QC that is required to actually perform that properly and safely, even on the old guidelines, that is really what is needed. However, you'll see that the note at the top that says that each requirement kind of falls or builds on the next one. Over here, things are a little bit different because I don't believe you'll necessarily do 3A, B, and C. Or you won't, if you're doing C, you won't have done B and A necessarily. I think they are 3 very different types of institutions that would do the 3 of those. But still, even if you just do 3B, you will still need to qualify for everything there. There's an interesting thing on the facilities there. You'll see there's a grade C laminar flow, which is a requirement in a D background. Now, I don't know how many of your facilities actually have that or will comply to that requirement. It's HVAC requirements, there's all sorts of things. It's clean rooms, you have to dress in when you go through. And I have been to some of these facilities that have clean rooms, but there's no basin to even wash my hands before I go in. Understand? So we don't fully comply because we haven't thought of those things. And the reason is because we don't have the right personnel that necessarily design these facilities when you go in. So please do consider this and think where we want to be. What would you like to do? And let's see how we can help each other. So I've put the risks here just so that we can understand and we don't just think pharmacists are trying to hog the profession. If you look at the diagnostic radiopharmaceuticals, they don't have generally they don't have a pharmacological effect or major clinical side effects. You shouldn't be able to kill someone with a diagnostic pharmaceutical. Yes, there's exposure, yes, it's an event if it's a misdiagnosis or all of those things, but it's not, the danger really lies with therapy. So therapy we need to protect. It is new, yes, iodine has been there for long, and as I said, you normally get it in a capsule, and that's on 1A or 1B. So that's not what I'm talking about. It's when we start labeling these therapeutic drugs, administering them, that is when we really need to start looking at the risks, understanding the risks, and then complying to the guidelines. So I've just put a little summary at the bottom to say that diagnostic radiopharmaceuticals primarily have risk radiation exposure, while your therapeutic ones entail more complex dangers, and that's why you need suitably qualified people. So I've got some key questions, and I've been asking them as we proceed to say you need to evaluate what level is your facility on, what procedures or products are you currently doing, and what would you like to do, and then look at what operational level you then need to comply to. So the bottom one, I said, what can we do to get there? Initially, I had, what can you do? But I decided that because I've shown the value chain, it's not a you problem. It is a we problem. Us as industry, I mean, I come from industry, we need to support and see how can we offer assistance. And that's why I said, whether it be through, please do engage with us. I won't give everything away, but please come and talk to us and say, look, I want to do this, but I don't think I've got the right piece of people, I don't have the right equipment, or I can't do these procedures. What can you do to help us? So those of you that know me, I'm not only, I don't specialize in regulatory, but I do understand the regulatory guidelines. To me, this was how I could explain it, is it's like a circle of where your boundaries are. And if you don't understand the guidelines, you can safely play there in the middle. You won't necessarily grow, we won't go far, but we won't get in trouble, which is fantastic. However, if you do understand your guidelines, and if you really read them, interpret them, interrogate them, you can happily play all around the sides there. So I think I generally like to play on the outside because I'm part of the NTP's growth strategy team. So we want to grow the market, and we want to help the physicians to move into newer parts of nuclear medicine. So I just wanted to say, let's understand the guidelines, let's interpret them and embrace them so that we can move forward. Thank you.
Thank you. Thank you, Samantha. Thank you for the lecture.